Hello everyone and a very good evening. I'm Dr. Sumaya Nazneen, Manager Medical Services from Zuventus Healthcare Limited. On behalf of Zuventus, I welcome you all for the third episode of Series 2, E-Gurukul, Solving Clinical Dilemmas by Dr. P.C.Mahapatra sir. We have a very interesting topic for today's session, that is the tricks of obstetrics and logy of gynecology. And we are delighted to have with us none other than Dr. P.C.Mahapatra, who is a distinguished personality from the world of obstetrics and gynecology, as we all know. So I'd like to call upon Mahapatra sir to enlighten us on this topic. Over to you, sir.
Thank you, Shumaya, and the whole team of Juventus, the medical team, as well as the administrative team and the IT team for this continuation of this program, academic program, E-Gurukul, which has become a really a pressure on me also because my viewers are very much interested to see me and hear to me, and that gives an additional pressure. I'm not whether I can reciprocate it or not, I don't know, but I will still continue as a teacher for teaching till my last breath. Well, this is a very festive season, and all of you are engaged and celebrating the Navaratri, the 5 days before Navaratri and the 5 days after, and starting from Sashti, Saptami, Ashtami, Navami and Dasami. And Vijayadasami is a very gracious festival, particularly in the eastern part for that. The first five days, Navaratri has become very popular in the north and west, and the Vijayadashami has become very popular in the eastern part of India. And without this feminine energy, nobody can exist. And that is the reflection and concept behind Vijayadashami and Navaratri for that. As a women healthcare provider, I feel honored and I feel really something miraculous will happen under the blessings of this. And I wish all the family members of my viewers, all my gynecologists viewing this particular episode and saluting this particular great goddess who is the seat of energy for all of us, and seek the blessings for the health, wealth, and happiness of the whole society for that. With this initial background and the worshipping of this great divine, again, I bring greetings from the place of Lord Jagannath, who is nothing but a Dakshina Kali, and worship particularly in terms of that during the 9 Navaratri period and in Puri. Well, I'm so attached to this particular E-Gurukul series, and we have almost completed the first series 1, and series 2 has become very important on demand by the gynecologists who love me, and that's why we have started this particularly on the other aspects on the medical management for that. And today we will be dealing with the topic of tricks of obstetrics and logy of gynecology. Again, in continuation of my first episode, we will have this episode which can be particularly focused more, so that I thought that we should know ourselves much better in depth rather than the subject before going to the subject for that. And what is the status here? I think I will just give a glimpse of that. Now, the tricks of obstetrics and logy of gynecology is a very catchy name for me. I was just going through and I searched for it. Who is the person who has coined this word so befitting for us? Until today, I'm not able to find the person who has coined this word, tricks of obstetrics and logy of gynecology, obstetrics and gynecology, which is very apt. As far as obstetrics is concerned, the tricks is more important. As far as gynecology is concerned, the logy, the science is more important for that. And I usually, and many occasions also, I have told this and to my gynecologists, to my viewers, to very conference, CMEs and other things for that. And therefore, in the second part, again, I will highlight how to become a successful gynecologist and a successful professional for that. And that is what mainly the concern for that. And that is the main thing which I will just again reiterate it in this particular episode for that. Now, as far as the medical profession is concerned, when I go and I search for it, that medical, what are the oldest profession in the human race? The medical profession, the noblest of the noble profession, legal profession, the shrewdest of the shrewd profession, and the profession of prostitution, a profession which doesn't need any investment for that. And when we come to the medical profession, the medicine man, the history clearly reveals that they were worshipped as a priest, herbalist, or some people say that they are being a magician. They change. But without the knowledge of the medical science, all these persons were giving for years together, a thousand years before, when the medical knowledge is limited and we do not know anything, the aim of these particular people to bring relief to the sick in complete absence of medical knowledge. So either by nodding of the head, or by counseling, or by sweet words, or by some other than roots, leaves, and other thing, they were treating and showing that miracle for that. Now, I've divided into two particular aspects. The magician becomes an anesthetist. They give wonders for that. I salute the anesthetist. Without them, we don't exist also. And without us also, they don't exist. And on the other hand, the priest or the religious part, the surgeon and physician comes. But where from the gynecologist? What are the origin of us as the obstetricians and gynecologists? Where from you come? We show also miracle. We also show the magic. You know the science, obstetrics and gynecology, the mother and child, and the magician. We are also magician as well as the priest, because we believe in the destiny, because the two truths of life rest on us, the birth and the death. So we are a combination of all these, and therefore we are also included under that. That the great functions of women's life has for years made her the subject of specialists, male and female, the obstetricians. This is a quotation from Till in Obstetrics and Gynecology, 11th edition. And the subsidiary relationship of our special organs and the special requirements of our physics based upon these have necessitated the establishment of another class specialist, the gynecologist for that. I remember initially there was one of my old professor whose designation was MO. I was surprised when MD and MS was there. MO meaning what? Master in Obstetrics. Then I traced that yes, there were that time very old, our grand teachers, they're mainly dealing with the obstetric part for that. And later on, the subject of gynecology evolved in a very great way for that. Now, the medical fraternity, we have got three categories: the physician, surgeon, and gynecologist, as I have already told. And the temperament is different. The purpose is same, the alleviating the suffering of the humanity. That is the main basic. But the temperament, a physician has got two brains. They think that they have got two brains, and with the two brains, they can think and think anything in the world and win the world by thinking only. Whereas the surgeon tells that we have got two hands. We can make the world this side and that side by our two hands and turn it around and win the world by our two hands. What about the obstetricians and gynecologists like us? We have got two fingers. We think that the whole universe rests with our two fingers for that. And that's why we are unique for that. And gynecologists are really, all of you must have really introspection, day of introspection today, what you are now, what you were before, and what will be the future of that. And these are some hard facts I'm telling you as a gynecologist. These are the hard facts, believe it or not. We are a separate class. We are separate from other people because we enter this profession by choice, not by chance. Unless the dedication is there, we cannot be a gynecologist for that. And we are a strong believer of destiny. As I have already told, that we deal with the two truths, life and death. The baby is born, the mother is dead. And the science doesn't really explain all cases, and we are surprised. All of you must have experienced it. I have experienced that. Is a very sick patient. We think that the patient will not survive, and within hours or within days, and she survives and works from the hospital for that. Another group of patient comes very hurt and hearty and comes to the hospital by walking and lives dead. That is the situation, and we cannot explain in terms of science. And therefore, this is a zone. This is a zone which is a gray zone, which science is not able to explain. Maybe that in future, when our knowledge goes, when newer advances will come, we can know more and more about this. We mainly by labor, not by luck. And our luck definition is labor under correct knowledge. And that should be the luck for that. People think that we are lucky. See, where definitely luck factors is important. I always tell this. As far as obstetrics is concerned, luck is a very important factor for that. I remember when I was giving a talk on lady luck and labor and the AI Shoji, I said that yes, there are 4 different permutation and combination in obstetrics. Lucky patient, lucky obstetrician, excellent prognosis. Unlucky obstetrician, unlucky patient, worst prognosis. Lucky obstetrician, unlucky patient, unlucky obstetrician, and lucky patient. These are mixed prognosis will be there for that. And that's everybody has to admit. And I have also felt it during the period of 45 years of my experience in this particular subject, how important this is for that. And we live for others, don't live for yourself. You can't plan it. This is the thing, the physician can plan, the surgeon can plan, but we are the faculty which we cannot plan anything for that. And therefore, we have to live for others. Don't live for yourself for that. You have to compromise everything for that, for the patient benefit. And I salute all my lady gynecologists. I'm really fortunate in comparison to the lady gynecologists who really balance personal and professional life, because they are the nucleus of the family. We, the children, can survive without us, but the children cannot survive without the mother. And therefore, they really balance their personal and professional life. Work-life balance is more important for them, but it is very easy to tell, but difficult to practice for that. I hats off to that female gynecologists all over the world, and particularly in country like India, who balance it perfectly, these two. Otherwise, the science cannot grow and the family cannot grow also. Individually, we are very strong and powerful, but collectively, very weak and timid for that. That can be an approach for that, because there is a need for cohesion between us. We have a lot of cohesion in comparison to the other faculties for that, but still we say that it needs a more of coherence and cohesion and bonding between the fellow, all the fellows of gynecologists, and therefore will be strong, and therefore our community will be stronger day by day and powerful for that. We have a tunnel vision personality. We have a fixed idea. Only one thing, the profession, and don't think of the others. Even 3/4 of the life is spent for profession and don't understand the meaning of life also. There are many things other than the profession, which is we are one track minded, and that is one thing. And second important is that we don't have a time for other things to explore the life, and that may be a cause for that. I don't know, but this is really the negative feeling for that, and one should try to adjust with that and give some time for the meaning of life for that. The purpose of life you have to design for that, and you have to find out for that. We are bound to be exploited from everybody. Everybody, the public, the administrators, the authorities, and between our profession also, they exploit us. And we give a very good name as a professional hazard for that. Maybe the whatever name you give it, but this is a form for that. And gynecologists I have seen, they enjoy being exploited for that also. That is the unique quality for that. Even with exploitation also, for a few days, they feel very bad, but it is a nostalgic and addiction for that. They cannot leave their profession. Again, they come to the limelight and come to that mainly beginning their practice for that. We are highest ranking in society, but on social. I cannot say that they're anti-social, but on social. Believe me, you have got a very social functions for that, and you have gone there, and in the meantime, an emergency call comes, and you have to come back for that. Even for amusement also, you go to some area with the family, and halfway from that class, you have to attend to the hospital. And that's the meaning of that, that we are really unsocial. We don't think of future, only lives in present. We don't have an agenda for that. We don't plan our life. We don't plan our future for that. That's the greatest demerit of us. And we always begin whatever is present and give more importance to the present than to the future for that. Another unique quality of us is that a real amalgamation. Any professional, there are many professions who do the professions by utilizing their head. There are many professions who utilize their hand, but we are that category of profession who utilize all these three: head, hand, and heart for that. We have a heart for that. Everybody, you think about it. When there is a stillbirth and you feel more sorry than the patient. Patient cannot know how much involved you are when there's a problem. The gynecologist sentiment is quite different, that they feel really bad, and people don't understand the feeling of the gynecologist in that particular moment. They feel guilty, they feel they feel that yes, I'm really sorry for that, and that brings out to a different phenomena called empathy. People have a sympathy. Other profession is a sympathy. If there is something, they say that yes, there is sympathy. But empathy, I tell that gynecologist is an empathy. Empathy means something beyond sympathy, that you just reflect that position of that patient for you and imagine what you feel for that. And that's known as empathy for that. We have realized that. And lastly, we combine a unique combination of art, science, and commerce. The Trics of Obstetrics, the Logy of Gynecology. If these two are combined, commerce and commerce will follow us. And therefore, now you see that all the other faculties of medicine are envious on us, because all three are unique combination for that. We don't have any religion. It was a humanism is the main religion for that. And therefore, I say that we are separate class by itself. Now, initially when it started as a gynecology and obstetrics, then incorporated into gynecology for the other health issues, then now we find the subspecialties. The subspecialty is growing day by day. When I see, when I was a postgraduate, then when I was a faculty in the medical college, and over the years I've observed the evolution. My experience is that the subspecialty and super specialty have grown even in our field for that. At that time when we enter, there are many people who enter to select the obstetrics and gynecology because the subject is complete for that. And therefore, once they do the obstetrics and gynecology, MD and MS, nothing more than that for that. Whereas in surgery and in medicine, you have to again do a DM or MCH for the subspecialty and super specialty. Now, in gynecology also, people thought that it's a very small subject, but it's never small. It gives a universe. And this particular structure, I think the subject has grown up for the last few decades into various components and subspecialty for that, giving rise to gynecology, reproductive medicine, fetal medicine, high-risk obstetrics, urogynecology, minimal invasive surgery, medical genetics, sonology and imaging sciences for that, adolescent and genetic medicine, and many, many other subspecialty and super specialty are growing day by day for that. Now, have a close look on ourselves for that. And now, what is the status of us? From healthcare to medical care, where we must, our target should be healthcare, but there is an exception, paradox, that we are just going for a medical care for that. Again, a paradox, from disease to diagnosis, and from social identity to disease identity. Just to give a simple example for that. A patient is admitted in my medical college, particularly for labor. There are many patients who are there. Once they enter the particular hospital or labor room, the social identity is lost. Her name nobody knows. For the record's sake, they know it. But she is identified as a bed number 5, or she is identified as a case of eclampsia. She is identified as a case of placental abruption, or tells from the OT, bring that corpulus to particularly. But the social identity is lost. I think this is something which I feel that yes, this is the thing which is practically being seen all over for that. And from generalist to specialist and super specialist for that. From healing to treating. We have a different art of healing. And healing is God's giving the divine blessings on earth, that we treat and He heals, but through us. And from clinical sense to technological dependence. Now, this has become grown like anything. Gone are the time when we depend on our clinical sense, our two fingers and the pelvic examination can design and find out the diagnosis for that. Now the technology has grown up to such an extent, and it will certainly grow for that. So technological dependence is now for that. And I will come back when I deal with the pregnancy and all the thing for that. How we are dependent on technological dependence for that, when the subject of either an invasive like endoscopy or a non-invasive like imaging science modality has developed for that. We are dependent on that. Meaning thereby that the technology cannot replace us. The people think that yes, we can solely bank on this technology. Technology is absolutely necessary. This is a necessity for that, and this is a helping hand for that. And there should be a blend between tech and touch. And we cannot say that without touch, only by technological dependence they do it. And that is going to happen in future also, which I say that yes, the patients contact, the counseling part, the conversation, the expectation effect on the patient-doctor relationship, and our clinical examination, starting from the history, taking an examination. This is going to stay. But in addition to that, if technology is there, it will really accelerate and augment the many, many procedures for that. From rational use to irrational abuse, we either intentionally or without any intention, we are involved in some irrational abuse for that, either starting from a surgery or starting from the different medical management, the medicines abuse, we go for abuse for that. And everybody knows where we do that. And as far as science is concerned, I will request all of you that at least you should have a limit for that. And believe me, some sort of scientific rationality must be there, and before prescribing the medications or doing a surgery for that also. And this is obvious for that how we go for that irrational abuse for that. And from faith to court, we never see before during my undergraduate career really medical legal case for that. Now as we go on, now the medical legal cases are going on increasing, and the cause are many, because the rapport, the confidence, the faith between the doctor and patient is gradually decreasing, and there is a breach. There should be a breach between the doctor and the public for that, and that should be that is the main cause of this particular malady. And from faith to court, and now we have to be cautious about it also before any surgery, before any medication, and at the ultimatum after the result also. And starting from the mob violence to personal animosity to personal threat and personal thing to the court of law for that. There are a lot of things which can go for that. And I hope, I'm very confident that if you gird it, if you think, if you are giving a truth, particularly if you do not have any malified intention, I strongly believe that God is going to save you for that. Even if there is something for that, if you are not having a malified intention, think about it and treat it from the right. From pleasure to pain. I think earlier, if you see our forefathers, the pleasure of this profession, but now a pain is there along with the pleasure for that. And third, and the last thing which I will say, from charity to business for that. And therefore, we are really seeing the public, and this is one of the factors for this particular medical legal cases for that. And it is not a business. Health is not an industry. Health is a service for that also. I appeal, I pray always that yes, you may be in any institute, starting from your personal small hospital to a bigger hospital or a teaching hospital. Think about some sort of charity for that. And I believe strongly that our faculty, the gynecologists, have really this sense of charity in our heart, and therefore in day-to-day practice, they are much more superior from that. And therefore, it needs serious introspection. And lastly, I can say combine unity from we concept to I concept. That creates a problem for that. I is illness, we is wellness for that. At least we should think that we are doing it combiningly, and in terms of some adversities, all of us will combine together for that. Now look at its modern medicines. What are the modern medicines accepted by European universities as science only in 12th century? Until then, it was considered to be sorcery, witchcraft, mumbo jumbo, and magic. I've already explained in my initial introduction that there is no knowledge of medical science. The medical, in absence of medical knowledge, they are just treating for that. The purpose is to alleviate the suffering for that. Modern medicine, for all its breathtaking advances, there are a lot of breathtaking advances in technology, in conceptual advances for that, but it seems to be slightly off balance, like the Tower of Pisa. We cannot explain all these, and therefore it is just tilted for that. And why it is tilting, we do not know for that. But medicine is first and foremost an art based on scientific principles. It's not a true science. Believe me, I can boldly say with emphasis that medical science is not a true science. Where there is a hypothesis, where there is a presumption, it is not a science for that. A definitive thing, I think, in whole of the science, even physics has an hypothesis. It is not a science. Chemistry is a true science in some respects for that. And therefore, it's rather an application of existing scientific knowledge for the benefit of suffering humanity. And many people adversely comment on us that this medical science cure rarely, comfort mostly, but console always for that. There are some other views for that also by the anonymous statement. Dr. says, therefore, says, congratulations, today is your day. You are off to great places. You are off and away. You have brains in your head. You have feet in your shoes. You can steer yourself in any direction you choose for that. And I say that obstetricians and gynecologists has really brains on our head and really fit in our shoes so that we can, with the steering, we can go to any direction where we can be successful for that. And therefore, viewers, my gynecologist, in this particular great evening, obstetrics and gynecology is really a fast-paced. It is exciting. It's challenging for that. We all of you can experience for that. And there's a need also. The society needs, the individual needs, the family needs. 380 pregnancies per minute, 1600 maternal deaths a day worldwide for that, and advances in human reproductive technology, advances in surgical procedures, extremes of age we deal with, adolescent to geriatric for that. So there is a need, demand for that. And fortunately, with the concerted effort of all the skilled personnel, government healthcare providers, along with the government agencies and the different societies like Foxy and other forum, we have been able to tackle the threat of maternal death. And really, we have come a great ahead. And but still, there is a long way to go. We want to say that yes, no pregnant woman should die, and we have a limit of this death from three letters, three numbers to two numbers, and we are forwarding for one number, single digit number for that all over the globe, and particularly for the country like us. It's rewarding when we say that yes, I particularly entered this profession because it gives a lot of satisfaction. I'm really boasting of my profession. I'm proud of my profession, and then say that why? Because I deal with the patient and family-centered care, and I don't consider that it's a patient. It's a family-centered care. When a woman comes and the child, woman, and everything is a family. Everything has a nucleus in the family for that or then, and we don't deal with as the patient, it's concerned with the family. Everybody is concerned for that and family centered. There are important life events. We know that if you combine, if you see the life events of the male and the female, there is a clear distinction between it. We have a distinct phases in the female than the case of male, starting from the menarche, the adolescent, the reproductive age group, the menopause, and the post-menopause. We have a clear distinctive phases in the cycle of women. We do not have a distinctive cycle in the phases of the man for that. And therefore, we deal with that health care through life cycle for that. Where public education is necessary for that. And we are targeting, we don't treat only preventive medicine, both in terms of preventive gynecology as well as preventive obstetric practice is more important than the curative part for that. What are the trends in obstetric gynecology? We have really owned up with the technological advances, with the important concept in the knowledge for that, ultrasound. Not only ultrasound, the whole of imaging sciences has developed to a certain extent. And the man and machine has grown in a exponential growth for that. And now we see that this is a part and parcel for diagnosis, for interventional procedures, for therapy, and almost trying to compete with the invasive procedures like endoscopy. There was a time when endoscopy was a very important thing for that. Now, many of the endoscopic procedures now with the growth of ultrasound and imaging sciences, we are just ignoring and substituting with the less invasive procedures or non-invasive thing of diagnosis and intervention by ultrasound for that. The drops, newer innovation, oral contraceptive pill. Now, oral contraception, HRT, has become really a bonus for that and really a boon for now, because on the one, we want a maximizing effect and minimizing side effect for that. Once upon a time, when somebody tells about this, people are scared about it for that. Now, no more, we are dealing with. And when we come to the HRT, the life of a woman post-menopause must be absolutely maintained till the last breath for that. And this can have an additional value for the life in the postmenopausal period for that. As far as the molecules, newer innovative molecules we have developed over the period, the newer innovative molecules. I can cite few of the newer innovative molecules starting from misoprostol. The prostaglandins has become really an advances in the procedures of obstetrics and gynecology. Then some of the newer molecules like the oxytocin antagonist, the etoshiban group. I think the Juventus is a leader for that, and this also has become a really a molecule for that. The dinogest, the ulipristal, and the carbitocin now has come up in a big way. We are looking for more and more brilliant innovative molecules in the various aspects. In near future, I think a lot of newer molecules might come in the field of reproductive medicine, and all these innovative molecules, there should be a change in the pattern. No more always injectable for that, which is very individual bias, individual problem for that, and user-friendly molecules should come up with that, either weekly or monthly for that. Depot preparations will be of the molecule will be there, or there could be a new concept on the augmenter molecule rather than nutritive mode for that. The augmenter mode should be there. A neutral molecule might come out for that. So you give that neutral molecule, the absorption from the normal diet will be more. No more you have to give a nutritive mode for that, like iron, calcium, and other things for that. Only where there is a 10% absorption. This augmenter mode will be able to use it for instead of 10% of 80% absorption from the intestine. And therefore, no more we are using the even antibiotics. 500 milligram is not necessary. 50 milligram is only enough for that when there is absorption. I'm looking forward for this augmented molecule for that. I'm looking forward that the medical management is now growing much more for that. And therefore, day by day, this surgical intervention is gradually limited when the medical intervention will come, and future it will show for that, and this should be really a sign for the progress for that in the field of obstetrics and gynecology. Endoscopic surgical advances right from the time of 1980s when it is limited to the diagnostic, and subsequently when the video endoscopy has come out in the late 1990s, and we have done for endoscopic surgical advances for that, and this has become a boon. But it has now come out in a big way for that. We are just abolishing the major surgery from the opening to a large hole surgery to a keyhole surgery to a no hole surgery also for that. A lot of advances, particularly incorporated to the endoscopic surgical advances, mainly deals with the vision, the camera. This has grown like
Support? No problem at the support end, na? Hello, admin?
Yes, sir.
There's no problem at the support end, no? Because sir has got disconnected.
Yes, sir. सर इंटरनेट का प्रॉब्लम है.
अच्छा.
Not other issue.
Okay, connect हो गया. Sound is coming.
Hello.
Yes, sir. Sound is coming.
Now, what is the problem? Sorry, I'm really sorry for the little disturbance. I do not know. The technology is responsible for that. Now I think I'm connected well.
Yes, sir.
Yes, sir.
You can hear me, my dear viewers. Big apology for that and regret for that. But we are discussing about the trams in obstetrics and gynecology and up till starting from the obstetrics to the newer molecules to the reproductive technology and the endoscopic procedures. We have a lot of advances for that. We are cool because we are a unique specialty combining medical and surgical skills to address women's healthcare issues during the entire reproductive life cycle from conception to cremation. We are unique in that. I always say, repeatedly I'm telling this, that we are proud that we are healthcare providers from conception to cremation, and starting from the birth till death, we are there with the women for that. And therefore, we are boasting, we are proud of being in our profession for that. And at the same time, no other profession will have a variety like us. You will have a variety. In one day, you could spend time doing promotion of women's health issues, labor and delivery, ambulatory clinics, contraceptive or menopause counseling, surgical procedures in the operating room, laboratory or clinical research, ultrasound in obstetrics gynecology, reproductive technologies like IVF, and whatnot. In one day, you can have complete thing for that, dedicated to the women's health for that. And therefore, many people say, anonymous doctor, I also quote many times that there are three blunders in life. First blunder, to become a doctor. Second blunder, to select a doctor as a life partner, which many of you must have. And third blunder, to create doctors as a progeny, where some of you must have for that. And I have also done that same three blunders. Not only these three blunders, I've done a fourth blunder in my life, because I am a gynecologist, married to a gynecologist, my only daughter is a gynecologist, and my son-in-law is also a gynecologist. I've done a fourth blunder in my life for that, which many of you must have seen for that. But it's by choice or by chance, I do not know for that. Now, coming to the reforms. What are the reforms? We need the reforms, healthcare reforms in many aspects. For that, the quality initiative. Gone are the time, the quantity was mattering. Now the quality matters, and quality healthcare matters. And for that, you are responsible for that. The quality, how to improve day by day, the quality initiative. Pay for performance. This is also an important thing. There is no value for money for all equipments for that, and that will pay. Electronic health record, when digitalization has come up in a big way for that, it is a boon to the medical science for that. Electronic health record is important. And as a teacher, I feel that there should be drastic changes in education system, reformation of the education system, both in the undergraduate and more so in the postgraduate and postgraduate level for that. The postgraduate training, there must be a complete reformation and revamping of that medical education should be there for that. So that at the end, we must be able to provide bring up particular healthcare providers who can do a justice to the profession and justice to the society and our patients for that. Hospital is, and everything on lastly, and a scientific evidence for that. Always, we cannot be erratic on that. There must be some guidelines, some protocols, some recommendations, and within the limits of the science, with the rationality and scientific evidence, we practice science for that. Now, I always say will and skill really important for all of us as a professional. The skill development, therefore, every day introspect yourself. Every week you think on one day what wrong I have done in this and what could have been done to improve my scene for that. So skill development is ultimately, it boils down to the result. Everything boils down to the result. And if the result is good, everybody will follow you for that. And therefore, there are steps of skill development. Say, for example, from the time of training, when the clinical materials is more, simulation is not desired for that. As we find the clinical materials is gradually coming down, or the group of the postgraduates or the trainees are more, number is increasing, we are not able to have a one-to-one, and therefore simulation has a great role for that. And the simulation as a form of a learning is a very important for that. Mental imaginary, mental practice, very, people should be prepared. The will should be there for that. And web-based learning today, we are now, Corona has given us opportunities. We know earlier to Corona, pre-Corona about the different digital-based or web-based webinar for that. But now, during the time of Corona, and we have done the first series of cases we have done during the Corona period, and we really see the benefits of this web-based learning for that. And that is why you have given us and you have pressurized me to continue this particular program for that. Initially, I was not very much interested for digital, more interested. I say that I'm physically strong, but digitally very weak. Now I find that I can have an interaction with thousands and thousands of my viewers for that. And therefore, I must say that yes, web-based learning is absolutely important for that. Teaching and training in our operation room, that's important, teaching and training. We're doing a lot of workshops. And the workshop, the hands-on is very important for that. And therefore, surgery is a part which needs a guru or which needs a teacher. Under the guidance of a good guru or a good teacher, you see and you assist, you do it under that, and teaching and training module should be there for that. Ultimately, it gives rise to a good skilled doctor because skill is important for the professional. The greatest wealth of a professional is acquiring a skill. Once you acquire a skill, forget about it, everything will follow you for that. And surgical skill assistance, you must have it from the mentors for that, and you can really master it subsequently for that. So now there is a change from earlier we were saying that yes, see one, do one and teach one. It has changed from this concept to read about and see several, do many from simulation to our experience, and teach using effective and constructive feedback. You combine this, you can really be a great thing for that and a successful gynecologist for that. As a human being, to err is human, and that how it is there for that. Error results from physiological and psychological limitations of humans for that. And the causes of error are fatigue, workload, fear, cognitive overload, poor interpersonal communication, imperfect information processing, flawed decision making for that. So these human error for that. Now I'm thinking, I'm dreaming when artificial intelligence will come, the human error will be gradually diminishing for that. And I'm seeing when the data, more of data has become there. The only problem of the artificial intelligence is that a good data is necessary. As the number of data is increasing, good data is increasing, I think there will be a boon for that in future for that. And we have learned to avoid the error, and we compare with the civil aviation and military personnel for that, how they do it for that, because error has become devastating in that particular field for that. And we also borrow some of the ideas from these particular military and civil aviation in form of a checklist, and we are targeting for the checklist for that, the SOPs in the everything for that, the guidelines, protocols and recommendations we follow strictly. Many people have a guidelines, recommendation and follow that. The only problem is that all the societies have a guidelines and protocols and recommendations for that also. Protocols has become really very strict. So that's why we stick on the clinical guidelines for that. And clinical guidelines, the only problem of clinical guidelines is it should not be a contrast thing for that. One society gives a guideline, the other society gives opposite guideline for that. In many cases, we find for that, and that should be that should not be a misguiding us. That should be purely guiding us for that. And lastly, no blame culture, no blame game, and shame and blame culture. You just abandon from your mind for that. No blame game in the medicine for that. And therefore, you really, if you follow this, you can be a really great and successful gynecologist for that. Now, as far as the women's health care, we need 4 P's which are responsible, which are influencing with us. And it is not in our hand, particularly accepting the provider profile for that. The patient profile, the public profile, the provider profile, and the process profile. It's very difficult for that part of the human being to integrate all this profile and do the justice to the patient for that. In the patient profile, the education awareness has become gradually increasing for that. Before coming to you, many patients will come, particularly the next generation of patients. They come consulting many Google doctors and many theories. They know many things about it, but the things they know in such a way that misgivings may be there for them. They are panicking for that one. And you are there to give a proper education and proper awareness for that. Category of patients are different. So you are in a dilemma to treat the different category of patients. If a VVIP comes, you do more of active mismanagement for that. And therefore, this is only part which you ignore. You forget that this is a VVIP. Think about it as a patient and your existing knowledge and acquire that. And I think the patient will be benefited at the end for that. Expectation of the patient is more. Then say that, yes, when we consult a doctor, everything will be all right for that. I have already told, science cannot explain everything for that. And therefore, science has the limitations for that. And we are practitioners of science. The expectation, of course, on the part of the beneficiary is much above for that. And from prescriptive to participatory to directive practice. This is really a hazard for that. I have seen in my own practice, from the beginning of my practice, it was a prescriptive practice. I was prescribing one and the patient follows it from the beginning till end. Whatever I say, that this is in a form of a prescriptive. They don't raise, they don't question. Then we say that patients are educated. We must counsel them. We must tell the details why hysterectomy is necessary. This is the problem and all that. And this is, the patient is educated. There must be a participatory practice for that. Then they decide that, yes, these are the drugs which give it. These are this. So we counsel. That is the, for years together it continued. Now I find a little change. Directive practice. Patients are telling us that you do cesarean. Patients are telling us that you do hysterectomy for that. And that has become a directive practice for that. And we are confused on that. The patients need a quick heal and no problem. And quick heal and no problem. Immediately they come and they want 100 or 200% result for that. Only pleasure, no pain. So changing society, changing concepts should be there. And we must accommodate. We cannot say escape from this. And we must accommodate for that patient profile for that at your own ways for that. Public profile awareness has become grown up. The media, the knowledge, the IT, the internet and all that has given rise to a lot of awareness. Educational status of the patients have been increased for that. And more so, the attitude towards profession, our profession has become little really adverse for that also. And that also creates problem when something happens for that. The role of media, the legal perception and undue expectation. These are the 3 factors in the public profile which is affecting us in our day-to-day practice for that. And provider profile, again, I will see the first and foremost thing is a will and skill for that. If the skill is increased, I think that's really a unique thing for that. Your attitude and aptitude should be there for that. You must acquire a full knowledge on that particular skill. And not only knowledge, acquiring a skill. And not only skill of technical skill, non-technical skill is also required for that. And that will lack it. Only one track mind, we are targeting for the technical skill for that. And of course, I salute my teachers, the role of mentors. I think the role of mentors is very important for that. And always introspection and learning attitude. Every day, there is no age for learning. Every day in the age, even also today, I am learning, I am introspecting what wrong I have done it for that. That attitude must be there for that. And of course, work-life balance. You have a family for that. And you have to do something for that. You have a responsibility for the patient. You have a responsibility for the family. and balancing professional and personal life. I do not know how you maintain, and there are various methodology which I have also tried for that, but in many patients, many cases I failed, and in few cases I have become successful for that. Now, process profile, wherever you work, there must be a congenial working environment for that. The system simplification should be there. The policies and programs for women's health should be there. The role of ancillary personnel should be there for that. So everybody has a different place of working, and they are not deciding factors for that. A government system should be there. A hospital administration system should be there. And therefore, you have to cope with that and adjust with that to be a successful professional for that. These are methods of skill development, which again I must reiterate, the postgraduate training I have told, this is the fundamental thing. During the time of postgraduation for 3 years, I think this is a very, very important period in your life for skill development for that. And I always, as a teacher, find what are lacunae of this training, and revamping of this training and education is the need of the hour for that. And role of mentors, just by virtue of becoming a professor, you don't level yourself. I don't level myself as a mentor by simply acquiring a degree of a designation as a professor for that. I must, science is changing, it is dynamic, and as a mentor, I should also grow. And that's why I should also continuously become updated in knowledge by reading, by surgery, by everything. Wherever I do, we do it also. I think it's not the mentees who will do it only. The mentors is also responsible that the mentees will augment the knowledge of mentors, and mentors should have a teacher to know more and more things till the last breath for that. Specialized training is necessary for that. In post-graduation, we give a basic fundamental training for that. But after that, you need a specialized training in the different faculties. Suppose somebody wants a different specialty, he should be, after post-graduation, it is not possible during the 3-year period to level this. But the fundamental should be strong during the 3 years postgraduate, and specialized training is necessary. And this training should be ongoing learning skills. As I have already told, there is no limit for age for that. And learning from practice and introspection, whether from the failure, learning from lessons from the mistakes you have done it for that. If somebody tells that, yes, this happens and all that, casual, and that they cannot grow for that. And therefore, if there is a mistake, you should learn from your own mistake and gain from your mistake, learn from other mistakes also, so that you can be really proficient for that. And there should not be an ego. You should have an ancillary help. You should take help of your own colleague when needed. You should take help from the other faculties like surgeons, the physicians, as and when required for that. And lastly, you must do some search and research purpose for that. Have a bent of mind on research. I think clinicians are clinicians, surgeons. You primarily the research comes out of that also. I don't mean that don't do a pseudo research for that. But simply paper also, it doesn't suffice for that. But you have an academic bent of mind, and we are clinical disciplines for that. And if you target for that, automatically, if you think about it, lot of innovative ideas will come to you for that. Now, what is the tricks of obstetrics? Tricks of obstetrics, let me start and then end with the logy of gynecology and the last part to be successful gynecologist. These are the uniqueness of obstetric gynecology. Rule of 2. I always say rule of 2 is there with the gynecologist and obstetrics. Obstetrics and gynecology, the tricks of obstetrics and logy of gynecology. 2 finger, ring finger and middle finger are the predominant finger of us. 2 beings, mother and child. 2 routes of delivery, vaginal versus abdominal. 2 professionals, pediatrician and anesthetist, we must bank for that. 2 phenomena, at times many times we smile, but at times we cry also. And that is a combination for that. There are 2 truths in life, birth and death, I have already told. And aftermaths, what is the aftermath? Either the worship or rebuke for that. I think we and God are same. Till the work is done, we are worshipped for that. There is a difference after the work between God and doctors. God is forgotten, but doctor is not forgotten. Doctor is rebuked for that. That is the difference between these 2. Now coming to the skill development, I will just emphasize there are technical skills, there are non-technical skills. The focused areas in obstetrics regarding the technical skill. In obstetrics, what are those? pre-pregnancy counseling has become a very important. Pre-pregnancy care or prenatal care has become an important component for that. In antenatal care, there is a drastic changes in the concepts in antenatal care. No more the clinical examination and blood pressure measurement, taking weight, urine albumin, fundal height, that was limited earlier. Now there is tremendous advances in the concept of ANC because we have to go in depth into the fetal compartment because of the innovations of the ultrasound, imaging sciences and other biochemical monitoring. We go deep into it. Intrapartum assessment, there's a lot of pitfalls for that. Even if we do that, yes, whatever the CTG we do it, the tachydynamometer we do it, the fetal blood sampling we have read it for that, acidosis. There are a lot of pitfalls for that. And even the monitoring methods, intrapartum fetal monitoring or antepartum fetal monitoring, there's a lot of I think human error which is there for that. And this is an area where the scientists and obstetricians dealing with the subject incorporating the artificial intelligence in that. So there is a lot of studies in the world that yes, artificial intelligence, you do it, apply the artificial intelligence in addition to the CTG. I think the human error is obliterated and you can find a really improved method for that and accuracy for that. So intrapartum assessment, there is a lot of pitfalls. I always dream of, we have grown up in computer, we have grown up in electronic gadgets, and we have grown up till the stage of artificial intelligence. We want with that a single fetal sensor should be there. You apply the sensor during the time of labor and the interpretation, the artificial intelligence will say that yes, normal delivery will be there. And on the other end will say that the fetus, my life is only 1 hour, my life is 2 hours, my life will be absolutely normal if I go vaginal birth. How simply the obstetric practitioner will be there. You get it from the technology, the aid for that, the decision for vaginal delivery or cesarean section, they will give, artificial intelligence will give it. And the condition of the fetus will give it for that. And therefore, it is a really no more a stress for the obstetricians for that also. And we do not know there are multiple factors involved in obstetric practice in the labor process for that. And we do not know, every patient has become different. We do not know. And therefore, we learn problems in some cases. We cannot say that, yes, science tells us like that. So there is a lot of improvement in intrapartum physio assessment, though nowadays intrapartum sonography has come in a big way. And artificial intelligence incorporated to the fetal surveillance methodology will really go a long way in advances for that. Assisted vaginal birth like instrumental delivery, a lost art for that. Another time a lost art for that. But vacuum, forceps, these are still coming from high to low and then from low to none. It has come like that for that. And now vacuum, Odon device, some of the newer methods for that, assisted vaginal birth should be there for that. Prevention and management of obstetric emergencies. When there's an obstetric emergencies like hemorrhage, like injury, I think these are some of the cases can be prevented. And if at all it is there for that, it should be tackled as obstetric drills for that, like eclampsia, like hemorrhage. These are obstetric emergencies which has to be done for that. Now, coming to the operative delivery, like cesarean, still the changing trends and changing techniques is there. I've already elaborated during my surgical skill transfer, the series 1, where the mainly devoted to the cesarean section. 2 episodes I've done it with that. Again, I will highlight that there is a lot of changing trends and changing techniques for that. It's more refined nowadays as far as the mortality is concerned, as far as the morbidity is concerned, as far as the quality of the surgery is concerned, as far as the skill of the surgeons are concerned. There's a tremendous increase in the cesarean skill for that. But on the other hand, the overuse of cesarean section, the indications are gradually increasing so that the different societies, the government agencies, the WHO, all are targeting that you are doing increasing the rate of cesarean section. That has become a hot debate for the last 1.5 decades. And though I agree that there should not be a target of 15% or 10% for cesarean delivery, but still we admit ourselves that due to various reasons, this rate of cesarean section is increasing, and there must be, and many reasons are valid also for that, for the patient also demanding cesarean section on demand, and medical legal cases on the other end, unpredictable events which we do not know for that. It's not a mathematics that 2 plus 2 is equal to 4 always. These are factors which is responsible for increasing the cesarean section rate for that. But still, with that, we will all we practice science with evidence, and we'll all practice with rationality. We must say that yes, reduction of the primary cesarean section rate can really go a long way for that, and people should think about it for that, and people should introspect whether in this case I've done it, whether it's unnecessary cesarean section, I would have left it, whether delivery could have been there or not. I think this thinking should be there in the minds. I don't say that don't do more cesarean section for that, but at the same time I can say that yes, there should not be a target fixed on that. In various setups, it is necessary for that. The indications are growing. Elderly patients, the marriage, the late marriage, and by the time they go for elderly primary gravida, the abnormal presentation, the medical conditions which is coexisting with that, pregnancy conceived after the lot of efforts on the reproductive pregnancy loss, RPL, or infertility they conceive for that. These are some of the areas where there is no doubt you has to have a liberalization of the cesarean section. But the skill of cesarean section is also increasing. The surgical skill is also increasing. How to maximizing the effect and minimizing the complications for that also. Identifying comorbidities. The comorbidities are gradually increasing nowadays for that, and maybe medical emergencies, the medical conditions which are associated with it and all that, that could be responsible for that. And one thing I will say about the referral, you must be well knowledgeable and skilled to deal with the cases for that. But at times you need a referral. Your setup is different. Every setup is not same, the referral setup, and therefore you need a referral. Suppose an ICU facilities is not there and you need that, there should be an ICU facility for that also. You have to refer that. And in between also, there you have to refer. But you should know when to refer, how to refer, and whom to refer. Say, for example, when to refer. Don't refer it unless otherwise you will be criticized. The higher center will say that yes, this case very so early he is referred. If you refer late, so late he is referred. You are undone for that. How to refer is also important. Suppose in a case where a case of obstetric hemorrhage for that, you refer to a place. By the time he's transferred to the hospital to the higher center, in between there could be some adversity and patient will die, and a shock patient. So you must revive that particular patient, and the transit time also you must see that yes, patient is being really observed for that. You accompany that particular thing for that, and whom to refer is also important for that. To whom to refer, this is also important because your life is at stake when you refer a patient, and that time slightest small adverse comments on that particular thing will have a boomerang effect on that particular. So this is important. And critical care in obstetrics, this has become a really one step ahead of that in current situation of practice, where the comorbidities are there and there are sick patients who are there. You need a HDU or an ICU facility for that. In all medical colleges, in all referral hospitals, in all tertiary hospitals, the ICU facilities must be there for that. And obstetric ICU must be an important part for that. And the obstetricians and gynecologists should be aware of this particular thing, and they should know a little bit about the critical care in obstetrics. The things come to my mind. Just last month, I did a particular conclave with 500 gynecologists on critical care and obstetrics and gynecologists, and did a whole day program on that. It was really a brilliant thing. I thought that yes, this should be there for that. Critical care is something which has to be known by the gynecologist for that. And of course, the postpartum management. And lastly, the documentation. We lack in documentation for that. This is the truly demerit of us. Even I am responsible for that also in my whole life. Documentation is not very accurate for that also. I insist that as far as possible, you document it for that. Now coming to the details of these components of ANC, antenatal care. The antenatal education. Now patients are elite, patients are knowledgeable. So antenatal education should be there right from the time. You just examine the patient, take the blood pressure, see the fit lot, and just advise iron, calcium, and then dispose and come after 2 weeks. That's not enough. So antenatal education should be there. Build-up of the patient should be there. You have a counseling. What is your pregnancy? What is the physiology? Even you incorporate the Garva Sanskar and built up the boost up the mind of the patient, particular patient. There is a lot of panicky on the mind of the patient when pregnancy starts for that, and therefore antenatal education is absolutely a paramount thing, and we don't have a time for this, but I can say that you arrange some time, prepare yourself. Time is not an excuse for that, but the patient, you must interact correctly with the antenatal education for that. And screening for maternal complications. You should have a screening for maternal complications. Nowadays, innovative methods are there. You screen it right at the beginning of pregnancy, and you can know which are the cases we can go for a preeclampsia for that. So maternal complications, screening for fetal complications is important in the aneuploidy screening and all that as a part and parcel and advances in antenatal care for that. And immunization protocol, it's not only tetanus toxoid immunization, the various other immunization nowadays with the communicable diseases and particularly the viral diseases which has grown up like anything, and these are the cases where the immunization protocol should be really mandatory for that and expanded for that. Interventional strategies, you just preventive obstetrics, and wherever you find something problem for that, interventional strategies during the ANC is absolutely necessary. And last but not the least, a birth preparedness. You have given a date, expected date of delivery is this much and all that, but closer to the expected date or even before that also during the part of the antenatal education and counseling, birth preparedness should be there, both in terms of mental preparation and physical preparation, where to have a birth, delivery place and delivery persons and the institution, and this preparedness is be there for that. And many cases we have got in places where the government is also going for the transit home for that. When the communication transport is difficult in a remote rural area where the hospital is not necessary, and we are really targeting for 100% institutional confinement. That is the only way. That is the way where we have reduced the maternal deaths to a considerable extent in a country like India. And still there are places in hilly areas and where remote areas where the transport becomes a real problem. They usually have a transit home, and the government in many places, I don't know how far in other states is there for that. We have a preliminary in my state, it has already started for that, a transit home for that also. Now in the digital era, we can have a digital marketing, digital tracking of that particular patient right from the time of pregnancy and cover and have a very good favorable prognosis as far as the mortality and morbidity is concerned for that. Now, the contents of the care. What are the contents of the care? I've divided into two important aspects. The one is the booking visit and then the subsequent visit for that. This will rationalize the ANC for that. The booking visit, when the patient comes to you, importance of preconception care. If it comes before pregnancy, you must give it. And when it comes to the patient, first is diagnosis of pregnancy, whether it's a normal pregnancy or an abnormal pregnancy. There are many cases when it comes in early trimester, the abnormal pregnancy like an embryonic pregnancy, abnormal pregnancy like a threatened abortion, abnormal pregnancy like ectopic pregnancy or a molar pregnancy or some other abnormalities you can diagnose for that, a twin pregnancy or something we can diagnose for that. So diagnosis of pregnancy, no more the diagnosis of pregnancy rests within our undergraduate career and postgraduate career. We are giving a lot of importance on a clinical examination. There is nothing. No ultrasound was also there for that. In all cases, by the two fingers in the vagina, we see the size of the uterus, the consistency is soft, and Hager sign, Palmer sign, Jacquemer sign, all these were there. Now, no more these are valid for that. And these are all clinical guesswork is there. So diagnosis of pregnancy has become more clear-cut by the advances in ultrasound for that. And this can be good. Not only diagnose pregnancy, the gestational age accuracy. Accuracy of the gestational age is important as we go right from the beginning of pregnancy till end. At the 1 week, at the early trimester, first trimester, the variation of the sonographic gestational age with the clinical gestational age is 1 week. In the second trimester is 2 weeks, and in the third trimester is 3 to 4 weeks for that, even with the sonography also. But the gestational age estimation is very, very important to know the expected date of confinement for that. And there, in the booking visit, you must be little elaborate and find out what is the risk. Whether is a risk assessment, mother to the fetus. I don't mean that it is a high risk level, it is a high risk or a low risk. In all, when there was a time when we are dividing into high risk pregnancy and low risk pregnancy, then we realized that majority of the problem can occur in the no risk pregnancy. So no pregnancy is having no risk pregnancy for that. So therefore, there are some cases from the beginning where there are some associated high risk factors you can analyze, and there are some cases where there is a risk. You cannot, even if there is nothing, they are the low risk category, and you cannot ignore that particular individual for that. But the risk assessment, particularly from the beginning, gives a really opportunity to target and treat it for that. Now, many things comes as a basic investigation. During antenatal care, what are the basic investigations? You do it. And therefore, the hemoglobin status, the grouping RH status, the blood sugar, the thyroid status has become routine. Implement only TSH has become routine thing for that. Earlier, we were doing a VDRL routinely for that. Now it is done. I have seen why I'm telling about the basic investigation. A lot of gynecologists are in early pregnancy, toxo test, torch test is done for that. I think this is a misnomer, this is a myth rather than the reality. Those cases who really have an unexplained fetal death or in the neonate suffering from evidences of some element of cytomegalovirus infection or the other torch infections, then you do it. Otherwise, routinely this is not necessary for that. And therefore, there must be a limit for that. And if you, depending on the particular individualized problem or individualization of the case, when there is a comorbidities, you can do other investigations. But basic investigation, don't do much of elaborate investigations for that also. Role of vaginal examination, yes, a post-speculum examination is necessary, but not in all cases for that. And therefore, when the patient is bleeding, and you can say that it is bleeding means ultrasound, nothing is seen by that, and putting a speculum, you find a cervical polyp for that, the bleeding there, or a cervical growth could be there for that. So these are there, the limitations for vaginal examination should be there, but it is gradually decreased as imaging science has grown up like anything, and the role of sonography in obstetrics is very, very important. I always say again, reminding that a obstetrician is never a complete obstetrician without the knowledge of sonography, and gynecologist is not complete gynecologist without the knowledge of endoscopy for that. And therefore, role of sonography is absolutely important. Place of biochemical test. This is important. And add to the aneuploidy screening for that. And role of sonography, starting from the early pregnancy, you do an NT scan. It becomes routine in the social and Society of Fetal Medicine. SFM has really emphasized it, and this is of value for that. The role of sonography, NT with the aneuploidy screening of a double marker or a pentamarker, and PHGF screening, and this will add to the prediction of preeclampsia for that. So place a biochemical test, no more the quadruple marker, the triple marker, or even quadruple marker for that. And therefore, the biochemical test is very, very important for that. Another time when we see the down screening is only related to age. Now we find that yes, down screening can be there in a younger age group. So now I'm more focusing. It's my personal view. I may be wrong and all that. But NT, I do it. Even I do NT and NIPS in all pregnancy. Non-invasive prenatal screening, I do it for all, because initially the NIPT was costing more and it is not affordable for that. And therefore, when I did in my own studies, 1,000 cases of NIPT, only 18 cases I got over a period of years. 18 cases where the 18, 13 and 21 is positive. So I thought, why to do so much of invest? I asked my genetic lab and they said that yes, if I told them if you do these three, what will be the cost for that? And they are doing it with 3,500 or 4,000 rupees for that. And therefore, I have made a routine for the last 1 year. Routine NIPS screening for all. I don't want other whole genome sequencing for that. All chromosome analysis. I want these three. And they are doing, that is affordable. Patient can do that for that. So therefore, aneuploidy screening is important. That must be there in all pregnancy for that. And in addition to the aneuploidy screening, the prevention or prediction of the preeclampsia is important, with or without color Doppler in that case. Medications, nutrition has to be given for that, and always counseling for that. And all visits, you do a good counseling, and that will boost the morale of the particular patient, and pregnancy can go. Now, the subsequent visits, what are the subsequent visits? There is a confusion about the number of visits. Many guidelines has differ. How many visits will be there? Initially, when we say that yes, 11 to 13 visits include from the first trimester till the last, till the delivery we do it. Then the problem of the more number of visits should be there, and SUG guideline and other FOXI guidelines should be there also. There 3 to 5 visits should be there, 5 visits out of which 2 visits must be there in the late pregnancy for that. So that will depend on the pregnancy status for that. Patients requiring more visits, say for example, a comorbidities, a diabetes mellitus, a JDM will require more number of visits for that. A IUGR that requires more number of visits for that. So this is an individual judgment for that. But the quality of care should be good. Interval history, interval sonography, clinical examination, maternal serum screening. I always say screening for GDM has become a routine thing for that. After DIPSI associated with the FOXI, I think we have really done a great deal for 75 gram routine screening for GDM and one step test for that DIPSI criteria. And hats off to Dr. Sesia for that. Role of sonography. Earlier, sonography, I seen the evolution of sonography in pregnancy. Only one sonography was there, 18 to 20 weeks for the TIFA scan, anomaly scan. No more for that. But now, the pyramid has reversed. I think 11 to 13 weeks is more information will be there. Not only it can give evidence of NT screening, not only it can give an early congenital malformation and assist it in predicting some of the comorbid, some of the future complications like preeclampsia. The gestational age accuracy is more important also for that. So 11 to 13 weeks has become routine part for that. Then the anomaly scan should be there. And in selected cases where when a fetal echo, in some cases where there is a previous history, and of course, in the late pregnancy, interval growth scan is absolutely necessary, one between 28 to 32 weeks, and then subsequently also for the fetal. Otherwise, we have seen the stillbirth is more common from 34 weeks onwards for that. If you find an IUFD, there is a graph which has been seen that up till 24 weeks and beyond up till 24 weeks, this is more common, and after 34 weeks, this is more common. From 24 to 34 weeks, the fetal profile goes uneventful and normal in normal cases for that. So therefore, more frequent interval growth scan should be there in the subsequent pregnancy for that. Screening for Rh antibody is routine part for that, and therefore purpose, frequency, detailing, interpretation, and reporting of the sonography is important. And here I give importance to the gynecologist or obstetricians doing sonography alone rather than the radiographer for that. I know that there are some radiologists who do good sonography, particularly this SFM people, Society of Fetal Medicine, go in depth for that when the newer machines have come in a big way for that. Now, place of color Doppler. People think that color Doppler is really unique thing for that. But basic sonography, color Doppler is not necessary in all ways for that, but it is certainly important. Color Doppler is important for prediction of preeclampsia and early pregnancy and in cases of fetal growth restriction. So FGR or IUGR, the color Doppler is really important in obstetric practice for that. Importance of DFMC, clinical criteria, you cannot ignore for that. And importance of weight gain, clinical criteria, you cannot ignore with advances in that. Now, after that, you continue the antenatal care, then the birth preparedness. I tell again emphasizing these two words, expected date of delivery versus expected period of delivery. This is more expected. EPD is more important than EDD. EDD, you give a date, hardly 4% will deliver on that particular day. 80% will deliver 2 weeks before and 1 week after. That is known as an expected period of delivery for that also. So EPD. And therefore, in some cases also there can be a preterm labor which requires preparedness in early cases for that. And therefore, very important is a birth preparedness. When we are talking about institutional confinement and ignoring about the domiciliary delivery, this is very important that the place, the institution, the place, the person, and the whole team should be involved in that. So I give importance on expected period of delivery. You always say that you give a date, people think that on that day I will deliver. So they call just 1 week before the relations, the mother and all that to be there. But unfortunately, 2 weeks before the delivery occurs when the mothers are not there for that. So therefore, you must convince that yes, expected period of delivery is a different thing for that. So therefore, there is a need for perinatal education class and antenatal education class has to be there for that. You just do not only counseling, but different exercise during pregnancy, advice regarding nutrition during pregnancy, the different, the husband and the different party interaction with the relations should be there for that, and deciding the place of confinement for that. And that has to be really, whether it needs a first level at a primary level or a tertiary care level, you decide for that. And care providers should be there level wise, put expertise, the facilities, all things could be there for that. But one thing, the birth preparedness, I must really emphasize on that. So what is the future? In future, what we need? There is a need for reducing number of visits, recognition of the vital periods of gestation when the ailments will occur. When there is a problem, you identify the vital periods of gestation, and prevention of prediction of abnormalities, both maternal and fetal. The role of simple non-invasive tests for screening, and rather than an invasive method for screening for that. Improved imaging techniques. Now imaging techniques has grown up like anything, but in future, I hope that they will go more in depth into that fetal behavior and outcome prediction. Fetal outcome prediction could be there. By sonography, we have learned many things, but I expect from the sonologists to see in the future that the outcome they will see, that this fetus, the duration of the fetus, fetal life is 4 weeks or 2 weeks or 6 days or 1 day. So these are the things of fetal behavior and outcome prediction. Alarm signals in the era of electronics and computer, I always tell. Cheap technology should be there. There could be alarm signal during the time of pregnancy, and it's possible in the era of technology, and therefore the notification will come that yes, this is the abnormality which I'm got within this period of pregnancy. Like your mobile notification will come in the cheap technology for that. Teleconsultation is not the be all and end all. I don't say the teleconsultation. In obstetric practice, I've seen adversities of only teleconsultation for that. And I always believe that physical is also important apart from the WhatsApp message and all that. They go and record it and ultimately capsize to an IVFD for that. Home visits, outreach services in cases where there is a problem in the place. Societies are responsible, government policies are responsible, the need for revamping maternity brand hospital. In obstetric practice, I have seen in my childhood, there is a brand maternity hospital. Now you do not find a maternity brand hospital for that. When there is a strictly maternity brand hospital, I think the prognosis is much better. The cesarean section will be less. The patients are prepared whole day. The whole team is prepared for one purpose, for obstetric purpose for that. So there is a growing exponential growth of ART clinics, exponential growth of endoscopic centers. I need the revamping of maternity brand hospital should be there for that. And of course, the pregnancy card. As soon as the pregnancy is diagnosed, the government should have an agency for a tracking system for that. And there is easy now with the digitalization, the tracking system for that. There must be given information. This is your day for your checkup. This is your day for immunization. Have you taken these medicines or not? Have you taken the insulin or not? These are all can be done with the digital thing for that. So, my viewers, there is a antenatal care paradigm shift. No more the 3 things like blood pressure measurement, weight measurement, urine albumin, and fundal height for that. The changing philosophy, changing concepts from nodding of head to technology-aided intervention, from maternal focus to fetal focus. We have gone deep into the fetal focus, and from stethoscope to high-resolution sonography, from urine albumin to genetic and biochemical screening, from invasive to minimal invasive procedures, from traditional care to selective risk approach individualized care, and from sick mother to healthy mother, from ignorant patient to participatory patient, and from human intelligence to artificial intelligence. Artificial intelligence cannot override the human intelligence, cannot substitute for human intelligence for that. But if they do combine with that, I need the place for artificial intelligence in obstetric practice will go a long way for the benefit of the patient. And there is a sea change over years for that. So we are all working together to one end, some with knowledge and design, and others without knowledge what they do. And this is little bit about the labor. We have done an antenatal care in labor process. Why human labor is difficult? Unlike the veterinary labor process, human labor is difficult because of some reasons for that. First and foremost is an evolutionary impact for that. When you are having a 4 legs, a quadrupeds, converting into a bipedal attitude. Bipedal attitude and encephalization is the two most drawbacks for the human labor to be difficult for that. From the quadrupeds to the bipedal attitude, what happens? In the bipedal attitude, what happens? Before a human being, a child comes and stands up, the pelvis is circular, pelvis is uniform. Now, when the weight bearing is there, there is a altered shape in the pelvic beam, in the cavity, and in the outlet for that. When we talk about pelvis and teach about pelvis, we see that the beam and cavity and outlet, there is a lot of changes for that. When the head enters into the cavity, the transverse diameter is widest. When it lifts into the outlet, the anteroposterior diameter is longest, and therefore head has to rotate from internal rotation and then come out through that outlet for that. So why this occurs? This is because of the bipedal attitude, altering the shape of the pelvis, and in a different places in inlet, cavity and outlet, there's the reversals of the different dimensions for that. This is because of the bipedal attitude. Second important aspect in relation to the veterinary practice, the encephalization. As we in the evolutionary process, in the evolution ladder, we are supreme in that. The brain size, the head size also gradually increases in proportion to the body size in relation to the veterinary practice, where the head is the leading part for that. And the head accommodating the larger part, accommodation to the different levels of the pelvis wherever they are. I think that causes a problem, and therefore human labor is difficult. Second important fetus is a second patient. There are many occasions there is a maternal-fetal conflict for that. Gone are the days where we can ignore the fetus and only targeting the mother for the sake of the mother, we're sacrificing the fetus. But no more now. We have the fetus as a second patient, and therefore the maternal-fetal conflict can be there. But our main aim is to have a healthy mother and a healthy baby for that. There are many ill-understood mechanisms and factors in the labor process. There are some unpredictable and unfortunate complications, and there are some multiplicity of variable factors for that. And therefore, we really have a complacent attitude that labor, this happens, anything can happen, anything unpredictable can happen. Because the science is not focusing, because we do not have a booster antenna to prove that what is the problem, then we just have a satisfying with the complacent attitude for that. I think we must be above that complacent attitude. Changing scenario is now woman's choice. Woman's choice, woman's participation is important for that also. If this is not prepared to take pains for that, mentally prepared for that, you cannot do whatever medicines you can do it for that, and whatever skilled person you are for that. Role of technology is important. And of course, the defensive obstetrics practice for us. We see for the medical legal purpose, we want to defend ourselves and rather than the patient's treatment, and therefore many cases we do a defensive obstetric practice, and that is one of the reasons for increasing the rate of cesarean section from nowadays, and that's why difficult for the mother as well as the provider for that. Now, these are some again hard facts in labor and pregnancy. Every birth is a medical emergency, and no more they say that high risk and low risk. Optimum obstetric result is only on retrospect. Every patient will ask you, doctor, everything is all right? I always say till that time it is absolutely all right for that. I can't know. After the event, after delivery, I can say that everything is all right for that. Because obstetric result is only on retrospect. Most pregnancies, regardless of risk factors, result in healthy infants for that. Perinatal morbidity and mortality occur in pregnancies with no identifiable risk. This is important. So therefore, I say that only high risk categorization doesn't help for that. Perinatal morbidity and mortality occur in pregnancies with no identifiable risk. New factors may emerge unpredictably at any point of time. At any point of time, new factors may come out for that. And previous obstetric experience affecting the subsequent decision making, like obstetric bias, emotions, and apprehensions. These are all the human brain is there for that. Simple example I'm telling you, just you are going for a delivery and the baby is born, birth asphyxia, and we cannot revive the baby for that. In the coming week, suppose a patient comes again to your hospital and at 6 centimeter dilatation, light meconium stain, and head is below the level of the spine. You have a tendency that what is happened in the previous case, there was I couldn't save the baby, immediately decide for a cesarean section. That's wrong. So this is a fetal obstetric bias should be there for that. And therefore, this is there as a human being. I cannot say that this could not be there, but this is there with the emotions affecting that. But as far as possible, the bias and emotions should not determine your management protocol for that also, a decision for that. Pathophysiology is extensively studied, but least understood as far as the fetal factors are concerned. There is a wide spectrum of tests of fetal surveillance, but yet no single dependable test is there for that. Simple example I'm giving you. Fetal heart is 80 per minute, irregular, thick meconium stent liquor, and baby is born and Apgar score is 8 by 10. Another case, clear liquor and the fetal heart is absolutely normal and the birth asphyxia. And how can we judge? So I see that yes, I presume that the stress of labor and the sustainability of the fetus to the stress of labor differs from one fetus to other. The fetal resolve capacity is different, which we do not know, and that's why one fetus survives, another fetus doesn't survive for that also. So fetal adaptation to stress is variable, and we find that there is a gender discrimination also. If the female child is there, they sustain much better than the male child. And fetal adaptation to stress is much better if a female fetus is there than the male. This much in our experience we know, but there are many factors which is there for that. And obstetric practice has been surrounded by moral, ethical, legal, and professional issues for that. So therefore, obstetricians is a unique species, visualizing life and death at the same time, and therefore we cannot explain in terms of science, and therefore we are a strong believer of destiny for that. And provider, last is the provider. We analyze ourselves, that we introspect ourselves what wrong we have done here. Because from physiologic to pathologic, eutosia, dystocia, if the provider is wrong also, earlier we are telling the 3 P's, the power, passage, and the power, passage, and the fetus. This is important for the passenger. And now we add into these 3 additional factors, a provider, 4th P is also essential. So not only the passenger, not only the power, not only the passage, it is the provider which is abnormal, then the labor will be abnormal. So abnormality that can change from physiologic to pathologic, from eutosia to dystocia. So therefore, introspect yourself regarding the obstetric decision, obstetric skill, obstetric commitment, and last but not the least, I have already told about the luck factor, obstetrician's fortune. And therefore, if these 4 are there, obstetric challenges will turn into reality for that. Coming to the labor, therefore, the hard facts again, I'm reminded, obstetric emotions, obstetric bias, obstetric luck, obstetric promise, obstetric thoughts, obstetric identity, and obstetric addiction. These are all hard facts in the labor room for that. So masterly inactivity and watchful expectancy was there previously, but more of watch and more of action also is there for that. Therefore, it has changed from this to programmed labor. There's some adversities in a program. We cannot manipulate the labor process for that also, but we cannot prolong it for a long time also by inactivity for that. But ultimately, it needs a standard of care. Where from it will come? It will come from right decision. Where from the right decision will come? It will come from experience for that. And where from the experience will come? It will come from our wrong decision for that. And the message, therefore, the process of evolution towards positive direction. Amidst controversies, we reach at a consensus. We are fortunate and unique amongst medical fraternity because we are linked to process of creation and procreation. We are that category of doctors with the real human touch. We amalgamate art, science, and commerce, and therefore we will be the real winners. But now the present day obstetricians are at a crossroad. The obstetricians are criticized by government commission for performing too many cesarean sections and by the legal profession for performing too few cesarean sections. We are castigated for acting too soon on electronic fetal heart rate traces and prosecuted for acting too late on electronic fetal heart rate traces. We are criticized by women for making labor too regimented by the formulation of rigid protocols and chastised for making labor unsafe by failure to provide rigid protocols. And therefore, we cannot win. And therefore, many of the obstetricians have left obstetric practice and jumped into the newer gynecological practice like endoscopy and infertility for that. And this rate will go. I apprehend the future generation of medical faculty will visualize obstetricians as an extinct species standing with rusty forceps in the exhibition hall and museum next to Tyrannosaurus family in the Dinosaurus family, and I will designate them as a Homo obstetricus for that. But beware, we are obstetricians and gynecologists, we are not only gynecologists. The second part, the logy of gynecology, what are the things which is there for that? The focused areas on gynecology, as I have already told, that there are a lot of advances, adolescent, lot of segments, subspecialty, super specialty. Adolescent gynecology, infertility and pregnancy loss, menstrual disorders, preventive gynecology and screening, newer contraception, medical abortion, endoscopy and its spectrum, and imaging sciences. These are all focused areas, are all important. Operative gynecology, there is a changing trends. Urogynecology has become a really important part for that. Gynaecology, organ preservation and conservative surgery, need for newer molecules for that. Midlife management, psychosocial issues, and end stage management. Because we, from creation to cremation, so end stage is important for that, and the midlife management and post-menopause management for that. Coming to the gynecological surgery, past was a history, present was jittery, and future is a mystery for that also. And therefore, in the past, we see that cut and see. In the present, see and cut. But future, I will see. One will see in Great Britain, another will cut in India for that, another will cut. And the telemedicine will come out and telesurgery will come. Expanding horizons, only one is left to future. Delivering a baby by scope, is it possible? Yes, it is possible for that. Because we know the endoscopy, the mythology, Indian mythology tells that Arjun's reflection of water and sea attacks for that. Now we convert into Mahavir, theory of minimizing and maximizing, the Hanuman, theory of small size and maximizing. And therefore, when this will be there, enchanting a mantra, a 3 kg baby will be turned to 3 millimeter baby fetus, and we suck it through the hysteroscope, and outside we just enchant a mantra of maximizing. The 3 millimeter fetus will be converted to 3 kg baby, and we'll hand over to the couple for that. And Indian mythology, this is very important for that. Now, status of technology and techniques are changing in surgery, in gynecology, OR setup, instruments and gadgets, procedures are changing, robotics and telesurgery, and of course, everything boils down to the future will be in artificial intelligence incorporated with the gadgets, starting from the sonography is already come out, and in also in the different camera and in the endoscopic procedures is there. So we reach from crowd to calm and only OT, hidden instruments. Very few people or no people in OT, no cables, no tubes, automated camera movements, voice activated universal control, remote control, robotics and telesurgery for that. And this will be a situation of the future OR setup. Emerging techniques like robotics, single laparoscopic nodes, trochanless laparoscopy, and endo barriers will be the future for that. But the implications of the development of art and science of surgery focused on advances in robotics, virtual reality, digitalization, simulation, and we cannot but avoid the future of artificial intelligence for that. So, future of minimal invasive surgery. What next? Future minimal invasive surgery has all the content to flourish in 21st century. The day is not far when minimal invasive surgery shall be performed by machine with artificial intelligence, which may even have the faculty of digitalized clinical judgment. However, surgeons' conscience and intuition can never be digitalized, and that shall be the only difference between the human and robot surgeons for that. And expectation of the future generation of patients, when we look into it, they want it. Arrives in the office or home, from home. To us, they want an infinite amount of time, instant diagnosis, immediate treatment, no complications, pleasure with surgery, and lives with 200% cure. And that will be only possible when we, as a gynecologist or a physician, will be as a superhero when we can have a miracle healer for that also. The miracle healer, this is possible, everything otherwise with existing scientific knowledge, this is not possible for that. So future is the age of information, fundamental change from tissue and instruments to information energy, from objects and atoms to bits and bytes, from macro to nano, and from knife to chip. And Sarah, what Hutchinson has told, from the inability to let well alone, from too much zeal for the new and content for what is old, from putting knowledge before wisdom, science before art, and cleverness before common sense, treating patients and cases, from making the cure of the disease more grievous than endurance of the same. Good Lord, deliver us. Human reproduction, again, there is a changing concept for that. From hopelessness to hopefulness, from natural to manipulative, from prayer to science, from bedroom to laboratory, from sexual to asexual, from conventional family to unconventional family, and from man to superman for that. When we deal with this subject, again we'll highlight and detail everything on this aspect. Time doesn't permit me in this episode to continue all this. But the future is a designer babies, reproductive cloning, reproductive bazaar, and non-sexual reproduction for that. I quote Albert Einstein's tool. I fear the day that technology will surpass our human interaction. The world will have a generation of idiots for that. And that is what is Albert Einstein predicted for that also. Now, this is all about technical skill. We are forgetting about non-technical skill. What we have not read in medical schools, and that is to be projected for that. The communication skill is more important. We have to be, communication skill is important as regards the future aftermath for that. Counseling methodologies should be different for that. Managerial skills should be there. We are in a hospital set up for that. Everybody, you are a leader and you should be a good manager for that. You should have knowledge regarding time management. You should have a very well versed with the stress management, finance management, interpersonal relationship, and balancing personal and professional life. This will have a separate episode. We can discuss more and more in depth on this particular aspect for that. But the thing is that what we have not read in medical schools for that. Only the etiology, pathology, diagnosis, differential diagnosis, and the treatment were limited for that. This is the new expansion for that. Sometime we can have a indifferent episode for that. The 21st century is the best of times if one considers so-called scientific developments, and the worst of times when one critically looks at human development for that. And this is true. And as a surgeon, as a teacher, I fully accept this. Again, I reiterate, again, many times I have told this also. It will take me 1 year to teach the trainee how to do the surgery. It will take me 5 years to teach the trainee when to do a surgery. But it will take me lifetime to teach the trainee when not to do the surgery for that. And that's important for that. It takes 5 years to learn and do the surgery, but it takes 25 years to say not to do the surgery for that. Evidence-based medicine and obstetricians and gynecologists, search and research. This is really, we are stressed because of evidence-biased or evidence-bordered or evidence-based medicine for that. Because research produces this. I'm telling few things about research in this particular episode. Half of what man knows today would be proved wrong in 5 years' time. But the problem with mankind is that they do not know which half it is. 35,000 research papers per month in the medical journals, but less than 1% of it is making any mark in advancing human wisdom. 99% is creating confusion among the practitioners, replicating what the advanced West does to publish surveys. Knowledge advances not by reporting known facts, but reporting false dogmas for that. And problem of research and evidence-based medicine, those who publish do not work and those who work do not publish. This is a global scenario. Many people also say that you are wrong by telling this. But again, I will tell that yes, there is a need. The message will be that the more trained academic trained should be there. The academic bent up mind should be there. There will be more for a research, not for the papers for that. If data have been cooked and the results plausible, there is no way peer review can catch the fraud. It's Arnold S. Raman, editor-in-chief, New England Journal Medicine, has quoted this. The greatest discovery of the 20th century has been the discovery of man's ignorance. Nature has its own reasons always, but our reason cannot explore them many a time. There are some limitations of science of research. We forget that there are limitations of science of research. Quoting this one, Nobel Prize was given to J.J. Thomson in the year 1908, showing that electrons were particles. His worthy son, in 1937, J.J. Thomson, again was a Nobel laureate, received Nobel showing that electrons were waves rather than electrons were particles. Both were right or both were wrong, I do not know. But both the father and son were the Nobel laureate and all that. So this is research and science. Human body is something special, and therefore there are limitations of research. Doctrine of probability doesn't work always. Laws of deterministic predictability doesn't apply. Predicting the unpredictable is a dangerous sequence. The only certainty that works in the human body is uncertainty for that. And another thing we always do with the control. Normal man. Who is a normal man? Defining normal human being is another imprecise exercise in the present day medicine. Statistical definition of normal is mean plus minus 2 standard deviation in Gaussian distribution. 5% of normal population will be abnormal, so-called false positives. Results, there is a result of high-tech total body scanner. Out of 100 apparently normal individuals. Total body scanner high-tech has been done. And in normal people, we found 2,500 abnormalities detected without having illness. So who are the control for that? So therefore, all patients who are there for that, even if abnormality can be detected, they're apparently normal for that. There will be no well human beings at all. If one follow the modern medical and high-tech evidence, a well man would be one who doesn't see any doctor. When she goes to see a doctor to get investigated, she becomes a patient, and rarely ever does she have a chance to become well again for that. So evidence-based medicine has become evidence-modern medicine. It draws more controversies than consensus. Abundance and exponential increase in literature, statistical science prevailing medical science, and focusing on reductionistic science, shifting away from holistic science, genotype, phenotype, and consensus. We know what is a genotype. We know what is a phenotype, but research will prove what is a consensusness. And that three interactions will give rise to a disease. And drug studies, authenticity, research frauds, emergencies, pseudo-academics, and confusion. Easy access to internet, but difficulty in synthesis and application is a real part for that. Problems in the evidence-based medicine again, problem of well-managed control, dynamic human body versus linear mathematical model, that is statistics, reductionistic biomedical model, disease, organ-oriented rather than body and mind-oriented approach, research methodology, lacunae and pitfalls, discrepancy between in vitro and in vivo studies, animal model contemplating on human structure and function, de-emphasizing individual clinical experience, observation and intuition. These are all problems in that. Now, the last part, I will conclude with the key to be a successful professional. There is every demand wherever I go, the gynecologists say that, sir, in your experience with that, we want to share from your thing how to be successful gynecologist and professor. In many occasions, I have told this also, this can be a repetition for that, and I want this repetition to continue to give a more emphasis for all of you for that. And I ask you one question, whether you want to be a man of success or to be a man of value or both. You want to be a man of success and man of value both. So if at all you are a professional, we want to man of value and success both for that. To be successful professional, what are the foundations? The basic foundation is a postgraduate training. I've already emphasized this. The postgraduate training is very, very the paramount importance as far as the fundamental training for that. And for that, the institute is important. The faculty and mentors are important. And the sincerity, the hard work and dedication of yours during these 3 years are important. Whatever sincerity, hard work and dedication you have devoted during these 3 years, for next 30 years, you can be really win over the situation for that. So therefore, the basic foundation is a postgraduate training, a good mentor and a good institute is responsible for that, along with your dedication and hard work for that. Post-PG, along with that, now post-PG training and experience is important. What I find after the post-graduation, you are not producing a competent, full-fledged gynecologist obstetrician to deliver the all goods in a perfect way where you design for that. And therefore, the post-PG training or experience under a good mentor is important. Either a senior residentship in a particular institute or working under a good guide is important. That will bring your skill and enhance your skill to develop for the whole future for that. And remember, for the young gynecologist, for the patients, for my students, this part is very, very important for that. From the beginning, you take it with. Then I have found the decision for future. They are in a dilemma. Suppose my student passed MD from my college, and there is always every student has a dilemma after that passing. See, after entering into the subject, they feel satisfied that yes, I have become a specialist on that. And after passing out, there is more of dilemma, more of challenges, what to do and what not to do. And many of my students ask me, sir, you give some tips. I cannot give tips to uniform tips to everybody for that. There is not a uniform standard thing tips for all of you for that. But decide yourself what you want to be. To be a general gynecologist and obstetricians or selecting a subspecialty. If you are selecting a subspecialty like a reproductive medicine or gynecology, or there are various forms for that, urogynecology and everything. You mentally prepare yourself to devote whole of your time as a career fixing on that for that. Later on, you should not repent that, yes, my scope is limited, I should have a general obstetric. There are merits of a of general obstetrics and gynecology. There are demerits of this also as far as the competency is concerned for that. So if you decide for a selecting subspecialty, you become, from the beginning, you decide yourself that the whole of life will spend on that and improve on that. Training in different or if at all you are a gynecologist, a general gynecologist and obstetricians, at the same time, you are covering everything. And if you are covering everything, some sort of training in different subspecialties is important for that. Simply by passing MD is not sufficient for that. Basic requirement, you have some training in different subspecialty, apart from conference, apart from workshop, apart from scientific debate, scientific seminars. For that, you should have a training for important aspect. Say, for example, I've already told sonography is important for all obstetricians and gynecologists. Endoscopy is important for all gynecologists, particularly for that. And fetal medicine and the maternal health, maternal disease, I think the high-risk pregnancy cases, these are all an important part for that. Reproductive medicine is an important part. Urogynecology is an important part. Gyneco-oncology is an important part for that. So a short course training on that particular aspect will really update you if you are decide to be an obstetrician and gynecologist general. And sonography and endoscopy, I have already told about the two arms of the professions. Then, if you want to become a teacher, it needs a different involvement and dedication for that. You should, from the beginning, there are many students. I wanted to become a teacher right from the time of passing out for that. Because teacher is important. If you want to become a teacher, I think I will all advise you to have a very challenging situation more than non-teacher for that. Why? I say if you want a full-fledged teacher, teaching, you must be good at teaching. You must be good at clinical sense, the clinicians. You must be good in surgeons. You must be good in a vocabulary in transferring your knowledge for that. It becomes a all-round. I think all-rounder it should be there. And not only there are many teachers who are excellent surgeons, but they cannot teach well. There are many teachers who teach well, but they cannot do a surgery for that. But if you want a real teacher, you should be an amalgamation of an excellent teacher, a prolific surgeon, and an astute clinician for that also, and ultimately a researcher for that. So these, I decide that if I want to become a teacher, then you decide whether you enter a government service for that, because you are not the deciding factor. There are many factors around you who will decide for that. Entering a government service, it's not bad. Rule on the government and give in a serve in the periphery in a remote tribal part for that. I have experience for 3 years for that, entering a government service. I think don't feel inferior that you are in the remote place, you are doing nothing but. You can create everything for that. If you're interested, you can create, you can do all types of surgery in a remote PhD for that. That is my own experience for that. Some of you can enter a public sector, some of you can enter a private sector or a corporate hospital. Here the alluring factor is the money. And don't think that always money will pay everything for that, and don't sacrifice everything for that. You cannot be involved in a health industry. Maybe that you are in a health industry, but health services, bent up mind should be there for that also. And you are not the only deciding factor. Your family, your spouse and friends, if you have done a second blunder, your wife is a gynecologist or your wife is some other profession, a medical profession. I think you have to balance with each other, with the work and life balance, with the family and the profession and the spouse and friends. The need is to do there for that. You have a responsibility for your parents also. If your parents are sick, you cannot fly to London, America and leaving your parents for that also. That is another part for that. There are some people who do it, can do it, but many people cannot do it also. You have some responsibility for that. Settling abroad for that. And believe me, I imagine my situation. I've got a lot of offers when I passed, and after passing also, I got offers from the various places like UK and USA, and even in very reputed center in the postgraduate center, in particularly in countries like India also. But I have decided my theme in the future. Now there are two things I like it. I've decided that I will stay in my own home state. Second, I will make this state at par with all national and international standard for that. So I have established in my own state, and till today, whatever I am doing it to propagate that, yes, I will prove that this center is one of the exceptional center in the country as well as in the international level for that. And that's why I'm struggling. I don't know whether I'm able to do it or not. But this is an individual temperament for that, but settling abroad for that. And of course, changing profession. Many people change the profession and go into another profession. One important aspect, when they fail in their profession, they change it. When they're very successful, they change it for that. And therefore, this is the decision for future in that, changing profession for that. And to be honest, with a great, I think, expectation from all of you, I don't know whether you are happy or unhappy. And at this age, I want to experience along with that. I cannot leave my profession, but I want to make it a different experience on the profession and the politics I've joined. And almost this party has given me responsibility as the vice president of the party in the state of Odisha. I don't know what you can do it, but I have decided that I've entered politics not for convenience, not for comfort. I've decided that I've entered politics for commitment and conviction. And that is the rule where I'm really entering into it. But I cannot leave my own profession for that. This is just a sidewise I have told you. But you decide that whether focus on your profession first. I will all advise you that focus on your profession first. This you can. You are a social leader. You are a public image. And therefore, maybe that if God wants it, like me, God wanted it, I entered into it. But I will never miss my profession for that. I will never miss you. I will continue to do this webinar. I will continue to do this profession. I will continue to do the training as a mentor and mentee interaction for that. I assure you for that. But the basic need for a successful profession, what are the needs? Adequate knowledge is necessary. Will and skill is necessary. Sincerity is necessary. Hard work is necessary. Patience is necessary. Communication is necessary. Building rapport. Need of the patient rather than mood of yourself. Many people see, they decide that my mood is there. They govern by their own moods. The need of the patient is most important than the mood of the gynecologist for that. And above all, your personality development, you look at it. How to have a development of your personality in terms of anger, in terms of ego, in terms of complex, in terms of envy. Frankly, with the due confession to me, to all of you, I have tried my life for the last 45 years for all these elevation of anger, ego, complex, envy. I have sacrificed everything for that. I don't consider myself as something extraordinary, even less than average, even ordinary. And even I say that I know only 0.001% of the subject in obstetrics and gynecology. And this is the fact, this is the reality and all that. So interpersonal relationship, colleagues, seniors, juniors, other disciplines, paramedical and other staff, risk scoring and action, no risk, no gain. You have to take a risk. If you do not take a risk, no gain will be there. And of course, charity. Charity is inbuilt with many of you and all gynecologists. I believe that there is some sort of charity. But one message I will give it to the younger, next generation, don't run after money. Money should run after you. If you don't run after money, money should run after you. If you develop your own personality, if you develop your own skill and will for that, and tips and tricks of medical legal eventualities, you do it when starting from the record keeping to the rapport, to the communication skill, to the tackling of managerial skill, you can do it for that. And of course, you have a family and work and life balance has to be done for that also. And introspect always, fix an introspection day. Or in a 1 week, for 1 hour, you think about it, what wrong I have done in this week. And just by thinking that what wrong you think, automatically God will give you what right you will do it in next week for that. And that is the thing which is there. So 2 determinants of success is there. A strong commitment and willpower should be there, and divine's blessing. If either is there, only one is there, you are a failure. If 2 are there, depending on strong commitment and willpower is there, God is there to give you blessings, and divine's blessing will come automatically. If these 2 will conglomerate, I think amalgamate, you are really a successful gynecologist for that and a successful professional. Knowledge is the process of piling of facts. Wisdom lies in their simplification. Great minds discuss ideas. Average minds discuss events. Small minds discuss people. We have a habit. When we are in a group, we discuss about people. These are all small minds. Forget about it. But average minds discuss about events. But always you discuss about ideas and you'll be great for that. And that is my advice for that. The last words, in spite of all adversities, it continued to be one of the best professions in all centuries, our obstetrics and gynecology. Past, present, and future. Amidst pains, pleasure is there. We are more ethical, more moral, more human. We're amalgamation of head, heart, and head. We're amalgamation of art, science, and commerce. And therefore, I'm sure we are the winners for that. And medicine is a science of uncertainty and art of probability. With the art of probability and uncertainty, we'll practice scientific and rationality in medicine, and we'll certainly be the winners for that. And lastly, I will advise all of you, all my students and all my grand students. When I entered into the medical profession, my teachers were telling, medical profession, read and read and read. It's very tough. If you read it, you can make it for them. Now in sensitization classes to my juniors, to my students and grand students, I reverse it. I said that read less, think more. Read for half an hour, think for 1 hour. Talk less, work more. Have will, update skill. Target scientific development and acquire human development. Then only you will have a pleasure in body, peace in mind, and bliss in soul. And that will be a really perfect human being in future for that. And it's not only a successful man of value, man of success will be there for that. Thank you very much, my viewers, my gynecologists, and my team, Juventus, for giving me this opportunity to ventilate within this more than 2 hours, whatever I know for that. Thank you very much.
Thank you so much, sir, for taking your valuable time out and providing us with such an insightful and interesting session.
Thank you very much, sir.
Thank you, sir. Thank you very much, sir.
Thank you.
Are there any questions from the
No,
audience?
sir. There are no questions, sir, for today.
Oh, this is for motivational. Whether they are listening or not, I think
Yes,
they are
sir. Yes, sir.
I don't know whether I have motivated them or demotivated them for that, but I've just done my job.
Absolutely, sir. I
Please
think
stop
we are
the
also...
record.
Tech support, please go offline.
Sir, there are more than 150 registrations, I think, last when updated.
Right, sir.
So you have motivated me as well, even though I am not from Obs and Gynae department. But yeah, it was really interesting.
So I now think that I'm going in terms of in line with the mystics.
Right, sir. But definitely, sir, you have covered such a vast topic today. I think so. I think this is never covered in any of the books. I think that's the best part of it, sir.
Thank you. Thank you, Nilesh.
Thank you very much, sir. Thank you, sir. Thank you. Thank you very much, sir.
Thank you, sir.
Let Goddess Durga bless all of you.
Thank you very much, sir.
Same to you. Thank you, sir.
Shubha Vijay in advance, sir.
Thank you. Thank you. Same to you and same to everybody.
Yeah,
Thank you very much, sir.
Durga Puja, sir.
Good night, sir.
बहुत समय लगा 2 घंटा ऊपर ही लगे।